Hello, everyone. We will give everyone a chance to come into the webinar and join us, and then we will get started. Just a few more moments. All right, and welcome everyone. My name is Rachel Bromley, and I am TMA's Senior Manager of Patient Education Support and Advocacy, and you are watching TMA's Ask the Doc webinar series. I wanted to apologize for last month. We expected to have Dr. Danoff on last month, and I had a family emergency, and so we rescheduled for this month. But she graciously was able to reschedule and still come in and meet with us. And so we will have a wonderful time this evening answering your questions. It looks like we will have a more intimate setting with less people. So that means that we're definitely going to get to all of your questions. You can put them in the Q&A box. Go ahead and get that started. But first, I am pleased to introduce you to Dr. Danoff, and I will let her talk a little bit about her background and her current work.
Yes, thank you so much, Rachel. It's such a pleasure to be here today. My name is Sonye Danoff. I'm a pulmonary or lung doctor at Johns Hopkins Medicine in Baltimore, Maryland. And my involvement with the Myositis Association has been relatively long over time. I serve on the medical advisory board for the TMA, and I work with a group of doctors from a variety of specialties at the Johns Hopkins Myositis Center. My particular interest is in the way myositis can affect the lungs. And over the last 15 years or so, my colleagues and I at Johns Hopkins have spent a lot of time thinking about what are the risk factors that cause some people who have autoimmune myositis to develop inflammation or injury in their lungs, what we often call interstitial lung disease, and how can we best treat patients who have this involvement of interstitial lung disease. And then importantly, as patients get better, which we anticipate when we treat them, how do we know when to decrease our treatment or even stop as their lungs improve? So I've worked with my colleagues in rheumatology, neurology, radiology, people who work at the bench, all trying to answer those questions. And over time, we've learned a lot of things about interstitial lung disease. I might just start by giving a little bit of a background on really what we expect the normal healthy lung to do, and then what happens during interstitial lung disease. So the normal healthy lung should largely function as almost like a vacuum or collector of oxygen from the air. So the air around us is about 20% or 1/5 oxygen. And in the ideal situation, the oxygen from the air, it translocates from the air spaces in the lung into the blood. And it's carried on the red blood cells, the hemoglobin in red blood cells, to all of your tissues, your muscles, your heart, your brain. And it's necessary in order for fuel to be burned efficiently, much the same way that in an engine in a car, you need to have a clean air filter because you need the air to mix with the gasoline in order to burn efficiently. Similarly, that's essentially what oxygen in the blood does. It moves to the cells and it allows the energy in the cells to burn efficiently. Now, when this process is not working well, what can happen is that when a person exerts themselves, like if you get up and walk across the room or walk up a flight of stairs or carry groceries in from the car, instead of the muscles and the heart and the brain getting the fuel that they need, that oxygen that they need to burn their fuel efficiently, they don't. And that often will result in symptoms that are perceived as shortness of breath. Sometimes people develop a cough when they have interstitial lung disease. And often our patients will tell us that they feel very fatigued or tired. And again, a lot of this is really a function of the fact that the system that is burning the fuel is doing it very inefficiently. And so when we try to treat patients when we treat patients who have interstitial lung disease, what we're really doing is trying to reverse or limit the the damage in the lung that is interfering with oxygen being transferred effectively. Now, in patients who have myositis, typically the cause of this injury in the lung is actually the myositis itself. And even though we call it myositis, which suggests that it involves a muscle, in fact, it is an immune reaction that can affect a number of different organ systems. Some of you may have a form of autoimmune myositis that affects your skin, what we call dermatomyositis. Well, we sometimes refer to this as pneumomyositis, that is, affecting the lungs or the breathing organ. And when that happens, inflammatory cells will enter the lung, much as they would if you had, say, a pneumonia or a viral infection. Except in that situation, after the bacteria or the virus is gone, your immune system would leave the lung and the lung would repair itself. But in a situation where you have an autoimmune disease like myositis, the immune system perceives the lung as being a danger signal. And so rather than just going in, cleaning up something that's a problem like a bacteria or virus, it actually comes in and it stays. And when the immune system stays activated against the lung, it releases a lot of chemicals that it would have released in order to kill bacteria. But in this case, it's actually damaging the lung tissue itself. So most of our treatments for interstitial lung disease in the setting of myositis are very similar to what you might get if you have muscle disease or skin disease. And those are medications that tend to decrease the intensity of the immune system, or what we call immunosuppressants. Now, in addition to that, we want to make sure that there are no other things that could be damaging the lung, because when the lung is being attacked by the immune system, it's very vulnerable. So we'll also encourage our patients to do things like get vaccines so that they don't get infections with things like influenza or COVID. We'll also recommend that if they had been smoking, that they stop smoking, because things like tobacco smoke can also cause damage to the lung. And then another common problem that is encountered in terms of lungs doesn't come from the lungs, but actually comes from the gastrointestinal tract. And that is, some people have reflux, gastroesophageal reflux disease. And for patients who have symptoms of gastroesophageal reflux disease, we'll try very hard to control that symptom, because, again, as that acid refluxes up into your esophagus, it actually can also do damage to the lungs, because the tube that goes to the lungs, the trachea, is right next to the esophagus, which is the tube that goes to the stomach. And so acid that washes back up into the esophagus can actually cause injury in the lung as well. So we really are trying to minimize injury to the lung, both from your autoimmune disease as well as from other things which might be unintentionally causing damage to the lung as well. Now, interstitial lung disease is really kind of a general term, and you might well hear that there are other forms of interstitial lung disease. Many of our patients, when they look online, they'll look up interstitial lung disease or pulmonary fibrosis, and they'll read about other different types of interstitial lung disease. In fact, interstitial lung disease actually includes about 150 different types of lung injury. And some of these forms of lung injury are much more consequential in the sense that they carry a very dismal prognosis with it. Fortunately, in the context of autoimmune myositis, interstitial lung disease is often relatively easily treated. I can't say it's always easily treated, but relatively speaking, it's easily treated. And we're able to often to diminish the injury to the lung and to allow the lung to heal itself, to recover to a pretty good level of function. Now, when we think about this, one of the things that I mentioned that we're interested in is how the lung, why it is that some people who have autoimmune myositis develop lung disease, whereas other people don't. And we still don't entirely understand that. We do understand that there are certain autoantibodies that are associated with myositis, some of which are more likely to be associated with autoimmune disease, with lung disease than others. And for instance, there are a group of autoantibodies called the antisynthetase antibodies. You may be familiar with the name. Some of them are called JO1 or PL7 or PL12. Those tend to be more associated with interstitial lung disease than other types of autoantibodies. And some of those other autoantibodies are things like NXP2. So depending on which autoantibody a person has, it either increases or decreases their risk of developing interstitial lung disease. We also know that even within those autoantibodies, some of them are associated with more severe forms of interstitial lung disease than others. And for instance, there is an autoantibody that is called MDA5, and that one is sometimes associated with a much more severe form of interstitial lung disease. However, what it comes down to, and I think this is really the important take-home message, is recognizing that interstitial lung disease can be an important complication of myositis. And in some instances, it's the first sign of myositis. And so we've really spent a lot of time working with both our pulmonary and our rheumatology colleagues to increase awareness of interstitial lung disease, because what we do understand is that early intervention, that is recognizing it, treating it, will help to improve the outcomes. Now, one of the questions that I'm frequently asked is, well, how would you know that you have interstitial lung disease, or how might you suspect you have interstitial lung disease? And one of the reasons that interstitial lung disease can be difficult to identify is that the symptoms of it are often fairly nonspecific. And so these might include things like shortness of breath with activity, or it might be cough, or it may be fatigue. But you can imagine that all of those symptoms are actually fairly common symptoms. If you get a cold virus, you can have a cough, you can feel short of breath when you walk around. And sometimes it makes you tired too. So really the feature that's important is the persistence of those symptoms. And when we see that those symptoms are persisting, particularly in a patient who has a pre-existing autoimmune disease like myositis, it should be kind of a marker or reminder that we need to look into that. And so if a doctor thinks that you might have something going on in your lungs, they would likely examine you, listen with a stethoscope to your chest. And often there may be a sound that they describe that's called crackles. We sometimes refer to it as rails also. So there are some sounds that can be picked up on exam. But the other thing that we'll often do is a set of testing called pulmonary function testing. And some of you may be familiar with this. You might go into a room, have a nose clip put on, be asked to blow very hard into a tube, or else take some big deep breaths and hold the air and then blow it back out. And all of those tests are really designed to help us understand how the lung is functioning. And they're called pulmonary function testing. Using those, we're able to understand both how the lung has been affected. In other words, if the lung is still working well in terms of absorbing oxygen, and also how injury in the lung might be affecting the size of the lung. So when the lung is damaged in a condition like interstitial lung disease, the lungs actually get smaller. It's what we call a restrictive disease because they're getting smaller. And we can also measure the diffusing capacity to determine how well the lung is absorbing oxygen. When you talk to your doctor, if they do this testing, they might say to you, your lung function is some percentage of what we normally see. And so what we do is we actually use standards based on your age, your sex, and your height. So for each individual, we can say your numbers are, say, 100% of what is predicted, or maybe we would say they're 70% of predicted, or maybe we'd even say they're 35% of predicted. And depending on how severe that decrease is, we'll have sort of different ways of responding or different recommendations. Now, the second thing that you might notice is that a doctor may request that you have what's called a chest CT scan. And this is really just a much more kind of sophisticated version of a chest X-ray. And with that CT scan, we're able to see in a lot of detail the architecture of the lung. And so we can see if the normal lung architecture is there, and if it's not there, what are the changes that we can appreciate? Based on that, we will sometimes say, well, you have a certain pattern of lung disease. So you might hear a doctor say, oh, well, you have a pattern that we call usual interstitial pneumonia or UIP. Now, that doesn't mean you have pneumonia. Pulmonary doctors have only a very few ways of describing changes in the lung, and so we like to use the word pneumonia even when it's not an infection. So they may say you have a UIP pattern, or they might say you have a non-specific interstitial pneumonia or NSIP pattern. Now, the only reason why that matters is that actually also helps us think about what medications would be the most likely to be effective. And it also tells us, is this something that's very likely to be easy to treat, or is it more likely to be something that'll be a longer term problem where we might be treating for a longer period of time? So we've talked a little bit about what some of the risk factors are. We talked about autoantibodies. We've talked about sort of the detection of interstitial lung disease. So then the next thing that I think most people are interested in is the treatment of interstitial lung disease. And I've told you that one of the mainstays of treatment is immunosuppression, which is essentially the same kinds of medications that are used for treating other manifestations or other aspects of autoimmune myositis. And so the same sort of medications that might be used to treat muscle disease or skin disease or joint disease for that matter. Now, the thing that is a little different is that sometimes the exact form of the medication is slightly different. So there are now many, many different types of immunosuppressive medications, and there are some that are more effective for lung and some that are less effective. So when a patient who has myositis develops lung involvement, often the rheumatology doctor or neurologist who's seeing them may ask for a pulmonary doctor to see them to try to help with that part of their management, to try to choose a medication that would be the best medication specifically for taking care of the lungs. Now, there are other things that we suggest that can be helpful for our patients who have interstitial lung disease, and not all of these are medications. In fact, one of the most important things that we recommend is that people who have lung involvement or interstitial lung disease, that they consider going through an exercise program that's called pulmonary rehabilitation. And what pulmonary rehab is a monitored exercise program. It typically takes place over about a 12-week period, and it is usually 2 or 3 times a week. It's typically about an hour at a time, and about half that time is spent in an educational program, and half is spent exercising. And we find that for a lot of our patients who have interstitial lung disease, even if they haven't really noticed it, they have maybe decreased doing some of the activities they had done before. And so they develop a little bit of what we call deconditioning, which is essentially just when you do less, you're able to do less. And so this program is a very safe way of taking a person who maybe hasn't been doing quite as much, having them exercise at a higher level, but doing it in a way where they're monitored to make sure their oxygen level is good, their heart rate is good. And so that as a participant in rehab, you feel very safe that you're not doing something that is likely to hurt yourself. After pulmonary rehab finishes at 12 weeks, it's obviously important to continue to exercise because it would be a little bit like taking a medication and then stopping and thinking it would continue to help you. This is essentially a medication that you can give yourself that really helps in terms of both how you feel and how you do. The other thing that we also recommend in some subsets of patients who find that the damage to their lung has been such that when they exercise or do activity, their oxygen level in their blood actually drops down. We can measure that using something called a pulse oximeter. You might be more familiar with that because many people during COVID used pulse oximeters when they were sick to see if they needed to go to the hospital. If we see that the oxygen level is dropping below a saturation of about 90%, we will do a test to check to see if a person, when they're exercising, actually drops even lower than that. And so we may ask you to walk around the floor in the clinic, or we might even have you walk up a flight of stairs in clinic and check how your oxygen level is. And if that oxygen level drops below 88%, then you have met what is described as Medicare requirements for oxygen. And so at that point in time, typically we will prescribe oxygen. We'll tell you how much oxygen to use and under what circumstances. So maybe you might only need to use it when you're going out for a walk outside. Maybe you need to use it all day long, but that'll really depend on those tests and measurements that we do in the clinic. And we often will call that, it's an ambulatory desaturation test. Another test that's very similar to that is something called a 6-minute walk test. And that is where you're asked to actually walk literally as far as you can in 6 minutes. We measure how far you go and we measure your oxygen level. And that can also help us know how much oxygen you need. So those are some of the treatments that we do for interstitial lung disease and how we monitor as well. So once we start treating with medications, with pulmonary rehab, with using oxygen, we will see a patient back typically around every 3 to 6 months. If everything is quiet, we might see you once a year, and measure those things over time to see whether the medications we're giving are helping with those pulmonary function tests. We're also going to ask you questions like, do you feel like you can do more than you did before? Is your cough better than it was before? And we'll use those answers as well as that testing to let us know whether our treatment is working well. For some people, we have to try a couple of different medications because everybody is different, and what works for one person doesn't necessarily work for other people. So that's sort of a general background. Much of what I have been doing over the last number of years is actually studying these topics and trying to understand how to provide the best care for patients who have interstitial lung disease. So we've done a lot of work trying to understand particularly which autoantibodies are the ones that put you at the greatest risk. And is there a specific way that we could say, if you have this antibody, this is the treatment that will work best for you? We've certainly learned a tremendous amount over the last 15 years that I've been with the Myositis Center, but obviously there's still much more that we need to learn in order to understand how best to treat this disease. So Rachel, let me turn it back to you and see what kind of questions
Yes,
are.
that was amazing. I wasn't going to interrupt at all. You were on a roll. Thank you so
Of
much.
course.
And if you have any questions, please put them in the Q&A box and we will get to them. One of the questions that was submitted by email was kind of talking about, when we talk about myositis, we hear a lot of people saying progression of disease, and I had a flare or I'm in remission. Does ILD follow any of those patterns? Is it linear? Probably not. Is there a flare for ILD? What does that look like?
Yeah, no, thank you, Rachel. That's a great question. And, ILD, it's interesting because ILD doesn't necessarily follow the rest of the disease pattern in myositis, in the sense that sometimes the skin and muscle are doing great, but suddenly the lung is not doing great. So it does flare, it does go into remission, it does have can have periods of progression, but it doesn't necessarily go along with all of the other features of disease. So we will sometimes have patients who have come in and their muscle disease is under great control, but they suddenly notice that their breathing is not as good. And that can be very confusing if we really think of this as a kind of a muscle-centric disease. But I think that what we need to really think about it as a disease that can affect many different organs, including the lung. And so it can flare in the lung and still have everything else looking good.
So the other thing that I've had some people wonder if you have IBM, are you less likely to get ILD, and why is that?
Yeah, that's a great question. That is actually something we still don't totally understand. We think that there is something different about inclusion body myositis than there is amongst the other forms of, say, polymyositis and dermatomyositis. But for reasons we still don't totally understand, patients with IBM are less susceptible to developing interstitial lung disease than patients with polymyositis and dermatomyositis. And it doesn't mean it never happens. It's just it happens much less frequently. And so again, even in patients who have inclusion body myositis, if they develop new symptoms of cough or shortness of breath, we definitely would consider evaluating them for interstitial lung disease, but it may be something different. And because this breathing is actually also a muscular activity, sometimes it's actually the muscles being affected that changes the breathing. And so we will look at whether it's lung or whether it's muscle and try to understand what it is that's actually causing those symptoms.
We've had a couple questions come in, and someone has asked, I'm on a maintenance dose of Rituxan, 500 milligrams every 6 months. Are there B cell targets under this scenario?
Yeah, that's a really interesting question. So you're referring to a medication called Rituxan or rituximab. This is a monoclonal antibody that is directed at something called a CD19/20 cell. And what that means is it's an immature version of the type of cell that makes antibodies. So in your body, there's a group of cells called B cells, and B cells' job is to make antibodies. So what rituximab does is it actually binds to a very early form of B cells and gets rid of them so that your body can't make new antibodies. And it seems a little counterintuitive, but what we find is that when you use that, when you stop making new antibodies, it often blocks the autoimmune response. So that makes us wonder whether there are autoantibodies in everybody that kind of causes, that is sort of involved in the damage mechanism that causes interstitial lung disease. It's an interesting paradigm because it also is really the strategy we use for people who are getting IVIG, which is another treatment that some of you may be familiar with. This is IV immunoglobulin. And in this situation, what we're doing is we're giving you a whole bunch of normal, healthy antibodies. And we think that it protects the lung by confusing the immune system can't find the bad guy antibodies that cause disease and therefore can't damage the lung. So both rituximab and IVIG are essentially kind of different ways of accomplishing the same goal, which is to prevent bad antibodies or bad actors in the antibodies from causing damage to the lung.
Okay, the next question, this person is 82, and forgive me if I mispronounce this word. They think they have lipoid pneumonia from using Vicks for a long time. I've stopped that, but I have shortness of breath, a bad cough for a long time, and very tired. I thought I also had interstitial lung disease, but now I'm not sure. Maybe I have both. I've had DM for 12 years, and I take Imuran. What would you recommend?
Yeah, so that's so what you pointed out is something I should have mentioned sooner, which is that, there are many different things that cause interstitial lung disease. And, some of them are things that we're commonly exposed to, like medications, or in this case, like Vicks. So in people who are susceptible or who are at risk, they can cause lung injury. The lung is a huge organ that tries to clean out all the junk that we breathe in our air. And it has a very intense immune system to prevent the lung being the way bacteria or viruses or foreign objects get into the body. And so sometimes if there are substances like lipids or petrochemicals that get into your lungs, the body actually attacks those because it sees them as abnormal. Now, the fact that you have dermatomyositis, you also are at risk of developing interstitial lung disease from the dermatomyositis. Sometimes this can be, it can be helpful to talk with your rheumatologist about whether you should see a pulmonary doctor. Maybe you're already seeing a pulmonary doctor. Sometimes the patterns on the CT scan, which I talked about, can be helpful. It is very possible that you were diagnosed with the lipoid pneumonia after having something called a bronchoscopy, which is a test where you look down into the lung with a little fiber optic light and rinse out part of it. And if that's the case, then they may know that that's why you had lipoid pneumonia before. And if not, it's also possible that it was actually dermatomyositis back then that was in your lungs. And so sometimes it is a little hard to know right at the moment what's caused the interstitial lung disease. But I would definitely encourage you to talk to your rheumatologist and or your pulmonologist about that.
Okay, we've got someone with myopathic DM, and they're doing very well, but they wonder if there's anything to be done proactively. They had PFT maybe 15 years ago, and do you think it would be a good idea to repeat, even though currently they have no symptoms?
Yeah, so we have just gone through a process with the American College of Rheumatology to develop recommendations for patients in terms of screening and monitoring for interstitial lung disease. So for sure, if you have any symptoms like shortness of breath or worsening cough, I would definitely suggest you bring that up with your provider and see about whether they want to do either the breathing test, the pulmonary function tests, or whether they want to do a CT scan. But we do know that patients who have dermatomyositis are at higher risk of developing interstitial lung disease than the average population, and also some other subcategories of myositis. So I do think it's worthwhile asking about that. But the other thing I would say is that the best way you can advocate for yourself is to exercise regularly, because the thing that I always ask my patients is, are you still able to do the things you were able to do, 6 months ago, a year ago? And if they're still doing all of the things they had been doing, then it is really reassuring that their lung function is staying good. So that, I think, is probably one of the most important things that you can do for yourself in this situation.
I'm so sorry. And this person is the one that asked about B cells. And they are coming back to say, are there specific target counts for B
Yes.
cells when on long-term Rituxan treatment?
Yes, we generally look to see that they're undetectable. And so typically before you get your infusion, they'll check a CD19/20 count. And we typically look to see that the CD19/20s are undetectable.
I was curious when you talked about, you know, you get myositis. It doesn't necessarily mean that you will get ILD. Some people do and some people don't. But are there any current numbers on that? Percentages? What's the likelihood of getting ILD?
So that's a great question, Rachel. And it's one of the reasons that we have a pulmonologist who talks about this. With certain forms of myositis, there's close to 100% chance of developing interstitial lung disease. And again, this is going back to the antibodies that we were talking about.
Right.
So there are certain antibodies that are very highly linked to developing ILD, and those are particularly PL12 and PL7. With a more common antibody, which is called Jo1, the risk is lower, but it's still greater than if you had a different form, like, say, associated with something like NXP2, which is yet another autoantibody. So what we're really trying to dial into is which are the autoantibodies that confer the highest risk? And then if we know what they are, why is it that those are the ones that cause the risk? Because if we could figure that out, we might be able to block the pathways that cause the interstitial lung disease. Now, I don't want anybody to feel like, oh my God, I'm definitely going to end up with interstitial lung disease. That's not the point I'm trying to make. But we do know that having autoimmune myositis is a very significant risk factor, and that we want to be particularly mindful and careful in monitoring our patients with autoimmune myositis, because they can develop interstitial lung disease at different points in time in their disease course. Sometimes they'll present with it. Sometimes they won't develop it until years into their disease. And so it's just really important to not think of this as being just a muscle or just a skin disease, but really that it affects many different organs.
I might have missed this, but if you have myositis and you have ILD, does that mean you definitely have an autoantibody, or do some people have ILD without autoantibodies?
That's another really interesting area. So we only know how to test for a handful of autoantibodies that we know are associated with myositis. We probably test for about a dozen autoantibodies, but for sure there are more autoantibodies that people have that we don't know how to test for yet. One of the things that's been very exciting in the last 10 plus years is that we've worked with Oklahoma Medical Research Foundation, which has a system of testing autoantibodies where they can let us know if they see autoantibodies that we don't have a name for yet. And so we have about a third of our patients who have ILD who have unrecognized autoantibodies. So we just haven't caught up. Our knowledge hasn't caught up with that yet. Now, can you have ILD and not have autoantibodies? In myositis, yes, we do sometimes see people who have forms that are not classically associated with autoantibodies develop ILD, but it's much less common.
Someone would like an explanation of, you referred to autoimmune myositis.
Right.
And so if you could clarify that.
Yeah, and so that's, the names that we use for things change as we learn more about it. And so we used to distinguish between autoimmune myositis, that being polymyositis, dermatomyositis, and inclusion body myositis, because we thought that inclusion body myositis wasn't, like, when you look at the muscle tissue, it doesn't have the kind of inflammatory cells, the immune cells that we associate with, say, polymyositis or dermatomyositis. But then fairly recently, somebody recognized that there's actually an autoantibody that can go along with inclusion body myositis. So, when we use the term autoimmune myositis, it's not a very specific term. It generally means that it is an antibody-mediated disease, and that would put it more in the category of polymyositis and dermatomyositis, and slightly less in the category of, say, IBM, but definitely not. You can get it with IBM. So I'm sorry, the terminology keeps shifting, and it is very confusing.
Okay, we have a long one, but since we have time, we'll go ahead and jump into it. Okay, this person has DM and ILD, saw their pulmonologist yesterday and had 3 pulmonary function tests that indicated that her lungs are awesome, in quotation marks. I'm on 1,500 milligrams mycophenolate and am on a prednisone taper, currently down to 6 milligrams prednisone. And doctor said that when I go down to 5, I need to be very aware of developing any breathing issues. If so, he wants me to start on Symbicort inhaler. Have you had any patients that followed a pattern like this? This person also has asthma, but no symptoms now.
Yeah. So obviously I can't comment on your specific situation, but it sounds like you've done great, which is just what we hope for all of our patients who develop interstitial lung disease, is that when we get the immune system to kind of settle down, their lung will repair well and they'll come back to as good as things were before. It doesn't always happen, but that's actually what our goal is for every single patient we treat. And it's true, when we give a medicine like prednisone, it treats more than one thing. So I've had a lot of patients who told me that, when they started to come down on their prednisone, all of a sudden they noticed that their joints started hurting. And it's because the prednisone was treating both things. And so if you have a history of asthma, prednisone's really good treatment for asthma too. And so it may be that as you come down, some of your symptoms from your asthma come back. And, again, you don't have to treat it with the prednisone. I think your doctor's offered you a good alternative, which is treat it like you would treat asthma. But it is actually really interesting. We kind of think that when we give a medication, we're doing it's just going to have one effect. But obviously it has many effects on many different parts of the body. And I think maybe that was what your doctor might have been trying to communicate.
This person gets a gold star for asking this question, because I can't believe I didn't even think of it. We're talking about the air quality that has been so poor and extreme most of this summer. Do you have any suggestions for ILD patients who would like to be outdoors?
Yeah. No, this has been a huge issue. I never thought we would be dealing with it on the East Coast. I mean, clearly the folks out in California have been dealing with this for the last several years with the really bad wildfire seasons, but we definitely have not had nearly such a bad time on the East Coast. I think that there are a couple things to think about. I think firstly, you really should be mindful of the air quality alerts. If you are in a red air quality alert, I would not go outside to exercise. There are ways that you can get exercise inside. If you have to be outside, I'd recommend that you wear a KN95 mask, which the reason it's called KN95 is because it filters out 95% of the particles. And the thing we worry about is that, we can smell smoke and we can see dust, or we can see the smoke in the air, but really there are a lot of microscopic particles, and what they're doing is they're getting breathed in through your mouth and nose, and they're getting deposited in your lungs. And so what we're trying to do is reduce the likelihood that those particles are going to end up in your lung, where they're going to again stimulate the immune system and maybe make the situation worse, because your immune cells are trying to keep the junk out of your lung. And when it sees this huge influx of, dust and fire particles, burn particles, it's going to rush into the lung and try to get rid of them. And that could unintentionally hurt your lung. Now, if you're inside, this has been a really big issue because most of us do not have houses or air conditioning systems that are actually designed to handle the very small particles that come along with wildfire. So if you have interstitial lung disease or you have a sensitive family member with lung disease, I would actually recommend you get an air purifier to clean the air in the house. And when you're having bad air quality days, you may just end up being inside running your air purifier. We've had a lot of patients who have actually had those flares or exacerbations in this bad air quality period. And I think we're only just beginning to understand like what the impact is going to be. So I would recommend you be as safe as possible on those days and really, try not to be outside, especially not exercising in that weather.
My daughter will be glad to have you back her up on that, because we were going back and forth. We're training for a half marathon, and she gets these alerts, and she will not go. She's 19. She will not go outside. So our next question is, should ILD patients get the new vaccine for RSV?
I think that's a really great question. RSV is an infection that most of us get in our lifetime, and it is very noticeable because it makes people cough terribly. It can be life-threatening in babies. And really part of the reason we pay so much attention to it is children who get RSV can end up being put in the hospital or even having to go on a breathing machine from it. Fortunately, it's generally not as severe in adults, but it certainly can cause a lot of symptoms. My view is that if you have RSV vaccine available to you, it is not unreasonable to get that vaccine. I think that you should prioritize getting influenza and COVID vaccines, because at least at this point in time, those are the ones that are causing the most severe illness in the ILD patient population. But if you have access to it, and especially if you're going to be around young kids, if you have either children or grandchildren, I would certainly think about that. And you can also talk to your primary care provider about that and see whether they feel that would be appropriate for you.
All right. Well, thank you so much. That is all of our questions. I really appreciate you, as always, everything you do for the myositis community as a whole. And I want to thank everyone for coming today. Did you have any last minute thoughts that you wanted to share with the people?
No, I just want to remind each person who's here that you're your own best advocate. If you feel that you're having symptoms that you're concerned about, please raise it with either your rheumatologist, your neurologist, your pulmonologist, because they can't know how you're feeling unless you tell them. So please do feel empowered to tell them.
All right. Well, thank you so much. And everyone out there, have a good night. For TMA, I'm Rachel Bromley. Bye.
Bye now.